Welcome to All Things Cardio-Oncology. My name is Steve Caselli. I'm the Executive Director of ICOS. And in this podcast, you'll hear from a diverse representation from our community. We want you to be both informed and inspired by their stories and experiences, and we're so glad that you've joined us today. It's a pleasure to welcome to the podcast today two of our key leaders in our nurses working group. First, I want to welcome Anecita Fadol, who is Associate Professor and the Education Director in the Nursing Cardiology program at the University of Texas MD Anderson Cancer Center. She is also the chair of our ICOS Nurses Working Group. Welcome, Anecita.
Thank you, Steve, for that generous introduction.
Well, you are one of the most passionate and energetic people serving in our community, and we love the passion that you bring to your work. So it's so good to talk to you today. And we are also welcoming our special guest, Jessica Coviello. Jessica is Associate Dean of Faculty Development and a professor in the Graduate Studies program at University of Texas School of Nursing in Houston, Texas as well. And Jessica's likewise one of the key leaders in our ICOS Nurses Working Group. So welcome, Jessica.
Thank you very much.
It's great to have you. And today we want to focus our discussion around risk stratification in cardio-oncology from a nursing perspective. But first, Jessica, I wonder if you could just share with us a little bit about your professional background and specifically what led to your interest in the field of cardio-oncology.
Oh, thank you for asking that, Steve. So I've been in cardiology since I graduated from my diploma program a long time ago. So I have probably close to 40 years of clinical experience in cardiology. And that has extended from acute care settings in CCU through cath lab experience, all the way to cardiac rehabilitation and heart failure management programs. When I went into a joint appointment at Yale with a cardiology group in New Haven, it became clear as I was seeing patients with heart failure that there was a special subset of the population that came to me with a history of breast cancer and anthracycline therapy and or chest radiation. So I became very interested in looking at the trajectory of their breast cancer to the development of the heart failure. And I began to work with some of the cardiology group at Yale and at the university with Dr. Tish Noft, whose background is in oncology. And as I went through my doctorate of nursing practice experience, I did a study that looked at cardiovascular risk at women as they entered treatment for anthracycline therapy. And the questions that were being asked at the time were, what type of cardiovascular risk did women have prior to their treatment and before they even came to Yale? And what type of cardiovascular risk assessment was done at the very beginning of their journey? What did their cardiovascular risk factors look like? What were their lipid profiles? What were their cholesterol or what were their blood sugar levels and their hemoglobin A1C at the beginning of the journey prior to treatment, at 6 months and at 1 year? In addition, we also did echoes at those particular date points as well. So it became fairly clear that during that time, which was back in 2012, the women that I was seeing, the majority of them had not had their AHA year 20, a heart association cardiovascular assessment, which is the standard of care. All of us should have an assessment at the age of 20. And so they entered the system without having had a cardiovascular risk assessment. So in the context of this study, we found that women were entering with cardiovascular risk already. And so it was interesting to follow them as they continued their treatment during that period of time during the study. So that's how I got very interested in it. And I connected with Anecita Fadol, who had been in cardio-oncology for a while. I think we were calling it cardio-oncology or oncology cardiology back then. And she and Tish Noft really helped to inform me as I continued working forward. After this particular study, I did put a needs assessment into Smilo in conjunction with two of the cardiologists who were there also interested in cardio-oncology. That needs assessment was recognized by Smilo, which became the Yale University Cancer Hospital. And we began a cardio-oncology practice back in 2013. So that's how I arrived at this point. So thank you for asking.
That's great. Thanks for that background. That's super helpful. It also obviously introduces us to your background in risk assessment. Maybe Anecita, you can jump in and share a little bit about your experience in this area as well.
Oh, okay. Thank you for asking that. And Jessica, thank you for sharing your professional journey and how you got involved in cardio-oncology. Mine, it's like it happened like it's happenstance why I became very much involved with cardio-oncology. My background is cardiovascular nursing. I've been in CV ICU for the longest period of my professional experience. That's where I learned, the basics of cardiology and cardiovascular management. And when a position opened at MD Anderson, I was recruited there to become a nurse practitioner. So I didn't have any cardio-oncology experience, but when I was running a heart failure program at Kelsey-Seybold Clinic, I've noted many patients who have history of cancer, long-time survivors, presented to the clinic with cardiovascular issues. And that made me think like, oh, so these results in cardiovascular issues, meaning the cancer treatments, have some impact on the quality of life and the issues that the patients are dealing with after cancer treatment. So that got me excited. So when I came to MD Anderson, I was mostly focused on the heart failure because that's the practice I have outside as a nurse practitioner to begin with. But then transferring it to MD Anderson, these patients, many of the treatments that they receive can lead into left ventricular dysfunction, cardiomyopathy, or heart failure. So I was lucky to meet Jessica in, some time ago in the beginning of the oncocardiology program when we had the initial cancer and the heart meeting. So that's when, the experts in cardio-oncology at that time were gathered, and that stimulated more interest in the development of this specialty. And thank God, the International Cardio-Oncology Society was born, and they invited nursing to be part of it. And so there we are right now, in trying to develop this practice and helping educate, nurses, patients, and everybody that's involved in the management of the cardiovascular issues of cancer therapy.
Thanks. And I wonder, Jessica, could you tell us a little bit about how you have seen risk assessment practice through your different experiences at different institutions? How has it developed? How do you practice it now?
So I have a pretty straightforward approach to cardiovascular assessment, and I want to make a point that it's multidimensional. I use the American Heart Association app looking at cardiovascular risk assessment, and I look at a score for cardiovascular risk. In addition to that, we look at that within the context of the patient's trajectory as far as their cancer journey is concerned. We know that heart disease and cancer, although we see it as two distinct diseases, have really significant commonalities, which include these risk factors, also genetic, metabolic, and inflammatory components, and a shared preventative strategies. So I look at cardiovascular risk and cancer risk as a Venn diagram with this area of overlap in the center. And so it's looking at cardiovascular risk. It's looking at family history along with that cardiovascular risk. I look at the score. I look at their cancer trajectory as far as what's planned, what stage of cancer they're in, what the therapies are that they anticipate. And I also look at what an individual's daily life might be like. So part of that is just looking at what a typical activity level is for that individual as they go into treatment and how that's affected as they continue through their trajectory. So one of the things that's really very important to me is really related to activity through that cancer journey. And so making sure that I check in with individuals periodically through their cancer experience, and with our breast cancer patients, that's dependent upon what risk stratification we determine. And I make sure that people remain active, because we do know that remaining active during cancer treatment decreases their morbidity and mortality as they move forward. So I would say we look at all of those factors, the cardiovascular risk factors, the cancer treatment, histories of genetic diseases in the family, what the metabolic risks are and what the inflammatory components are, because looking at metabolic risk is an important part of looking at this. We know that women who go through cancer therapy tend to gain weight. They increase their waist circumference. Waist circumference is an additional risk factor when that expands. So we look at it in the context of treatment, and we look at it fairly broadly. So those are the tools that I use. I use the American Heart Association risk score. I look at that as the very beginning to start the conversation. I look at what an individual's typical day is like as far as their activity is concerned. I look at their current medication regimen, and I look at their cancer treatment as part of that, in addition to the diagnostics that we look at. So typically we look at echoes at the very beginning. We look at troponin levels, depending upon what cancer treatment individuals are going to be exposed to. I always look at C-reactive protein at the very beginning. And although many times we see that elevated because of the nature of the kind of cancer that they have, it's nice to get a baseline to kind of follow that as time goes on. So that, I would say, is typically how I go about looking at risk factors with our patients.
If you or your institution would like to have credentials that confirm your qualifications as a cardio-oncologist or a cardio-oncology center of excellence, we encourage you to consider applying for our certification exam in cardio-oncology or our certification for centers of excellence. These are the only certifications currently available in this field, and it's a special opportunity for you or your institution to distinguish yourself, recognizing your expertise in the field. More information about both these opportunities can be found at ic-os.org, or you can email directoricos@gmail.com for more information.
Anecita, I know that you have a very different approach, so I would ask you to share that with us.
Yeah, I mean, like, it's more or less, the things that you're looking at, but, I use a system, or a mnemonic, wherein you see, I'm a checklist person. Just like in nursing school, I have a checklist. So I have this in the imaginary back of my brain, easy for me to remember. When I follow up patients, particularly, in survivors, you're talking about breast cancer survivors. That's a typical one, because many of the patients that we see in the clinic are survivors of breast cancer, given their high survivorship rate. So, more or less in the same line that you are talking about, but then I look at it from these primary prevention side, particularly in the cancer, the survivors. And, it's the ABCDE approach, wherein awareness of the risk of heart disease. Are patients aware that heart disease is the second leading cause of death of cancer survivors? Because some patients are not aware of that. And then, if they need to have, or if there are candidates to receive aspirin, make sure that they're on it. B stands for blood pressure. Many of the patients have hypertension, which are uncontrolled. It's because they don't have symptoms. And many of these patients are taking blood pressure medications, but they're not aware what is the normal blood pressure that they should adhere to. So, I mean, I give them that number, and for the hypertensive patients, like I ask them, like to have a diary, ambulatory blood pressure diary, especially if they are titrated on medications, and bring it to the clinic. C stands for cholesterol, because, like in the preventive side, we need to make sure that they are controlled, and especially in those patients with high risk of heart disease and history of heart disease. And in patients, prostate cancer patients who are receiving hormone replacement therapy, they have a predisposition to develop high triglycerides or high cholesterol levels, and it predisposes to the development of cardiovascular disease later. Are they smoking? Some patients will not, if you forget to ask that, they will not admit that they are still smoking. And it is hard to stop smoking, but they should be aware that smoking is contributory to the development of cardiovascular disease as well as other types of cancer. And, it is difficult, for patients to quit smoking, but, they should be referred to behavioral treatment groups, or at MD Anderson, we have a tobacco cessation program. D stands for diet and weight management. You have mentioned about obesity. That is a most common problem, particularly in adult survivors of childhood cancer, because of the inactivity. So they need to be aware that they need to control their weight, and they need to adhere to a healthy diet. Also, in terms of those cancer survivors, they need to know we need to know what kind of chemotherapy they have received, because particularly in anthracyclines in breast cancer survivors, as well as, patients with sarcoma, other liquid tumors, children, have cancer when they were children. Many of them have received chemotherapy, anthracyclines particularly. So the amount of dosage that they have received, but in the literature it even says, there's no safe dose with anthracyclines, because this can cause a heart failure or cardiomyopathy in the end. Those patients that have received radiation, I have seen a lot of those patients who have received mantle radiation, especially if they developed cancer early in before the 2000s. And because mantle radiation therapy has been used then, and many of these patients have valvular issues, accelerated coronary artery disease. So these patients, we need to be really aggressive in controlling the risk factors like cholesterol, and if they're smoking, they need to stop. Then diabetes mellitus prevention or treatment. If they're diabetic, then they need to make sure that the blood sugar is or A1C is controlled. And then E stands for exercise. Patients, when I do not like to bring the word exercise, it's because what they think in their brain is be a gym membership, or go to the gym. I said, no, activity, walking, I had a patient who I asked, do you exercise? And she said, no, but actually 3 times a week, she's participating in a dance contest. She's doing these ballroom dancing. She's doing, the line dancing and all that kind of heavy exercise activity. So I said, that's exercise. So I've learned, do you participate in any kind of activity, instead of just saying exercise, because they'll say, well, no, I don't want to go to the gym. And then, of course, you mentioned echocardiogram. In patients with anthracyclines chemotherapy or different kinds of chemo, usually they will have a baseline echo. And then you monitor from there. And in the end, when they have, even if they still are asymptomatic, because in some cases, they are still, their heart is still able to compensate for it. The ejection fraction may drop, but they are still asymptomatic. So it is important that they need to have these measurements. And in many cases, in anthracyclines, you have the baseline. And then after a certain amount of doses, like 250 to 300 milligrams per meter squared, another echo, and then at the completion of treatment, and then in terms of monitoring. So in echocardiogram, I teach the patient to remember their ejection fraction. I said whatever, because many of them are not treated, are not followed up here also in the medical center. They're followed up in the communities or in another state, and they will have test, echocardiogram test over there, wherever they are. So I tell them to remember their ejection fraction. Although right now, like I'm not saying that ejection fraction is the gold standard of measurement, but at least that's something that we are following. And in many cases, you have these longitudinal strain, the global longitudinal strain, which in some institutions is used because that can detect left ventricular dysfunction early before the ejection fraction drops. So so I run through the ABCDE, and I always keep that at the back of my mind whenever I deal with a patient, when I teach a patient, either even in the inpatient setting or like in the outpatient clinical area wherein many of the survivors are followed up.
It's very interesting that you bring up two really important concepts here. One is patients' perceptions.
Correct.
Patients' perception of disease. And I know when you and I first started in this specialty, we met patients who came to our office and asked the question, why am I here? Mm-hmm. So patients' perceptions are really important. And along with that is patient education, which you clearly have delineated here for us today, the importance of patients knowing their cholesterol levels, their blood pressures, their ejection fraction, and also what they can anticipate as far as their trajectory and what they can do to continue to contribute to their wellness as they move forward.
Yeah, thank you. You really pinned the head, or like nailed the nail. Hit the nail there in the head, because patient education for me, first time I meet with a patient, I spend a longer period of time because I believe that patients should be involved in their care. And I teach them, detailed. And then I ask them, to, like a teach back, to tell me back, to make sure they understand. Because, like, for example, when you say in heart failure or left ventricular dysfunction, you'll say, these are the triad signs, that you need to watch for. But then when you say shortness of breath, but if you ask them, do you have that? No, I don't. But what kind of activity do you do? Most of the time, they're just sitting and watching TV, So how can you have shortness of breath without activity? So they need to understand what are the signs and symptoms they need to watch for and report to the clinic so that they can be seen sooner, and testing can be done and therapy can be initiated. So thank you for pointing that out.
Yeah, and I think the other thing that's really clear from our discussion today is really looking at the time that it takes to gather this kind of information. So I will tell you, Anecita, and I don't think you and I have ever discussed this, but my first visit is always an hour, just because of all the things that you've brought in as far as details that you want to be able to utilize, plus the opportunity for people to leave your office feeling safe.
Right.
They're all afraid when they come in to see us. And so to be able to provide them with enough information for them to feel safe, I think is really important.
Yes. That's why, this patient teaching education materials, to me, I have the patient education materials and I give it to them. I said, refer this when you get home, because yes, I sit for an hour and explain to them and I feel like they need to know everything. But then I said, I know you will not remember everything, but you can refer to this, this is, you read on it, or, right now we have a link, you can log into that and, so that it will remind you, or that will be your guide, everything I told you is found in that. So they can always refer to that.
Right. And I will tell you, one of the things that I've been thinking about over the last 2 years has really been looking at the social determinants of health and how that affects our population. And when you look at cardiovascular risk and cancer, we know that the incidence of both those diseases are higher in areas where the social determinants of health have been grossly affected.
That is true. It is very true. And then it is highlighted, with the COVID-19 pandemic.
Yes.
And we saw that a lot, but it is really true. I mean, in cardiovascular, cardio-oncology, like that is a big factor in some of these. I mean, in these patients who are affected with the social determinants of health, and how they're going to I will affect their treatment, their follow-up clinic follow-up visits, and in talking about that one, I mean, like the social determinants of health. Patients that do not have access, meaning they don't have transportation, or they can arrange for public transportation, but sometimes, they're unable to, telemedicine or video follow-up is very important with these patients. And in many cases for me, like, in heart failure, it's because the medications are gradually being up titrated. So when I see them in the clinic the first time and I start them on medications, instead of them going to the clinic in 2 to 3 weeks to up titrate the beta blocker, I just tell them I'll do a telephone follow-up with you or a video follow-up with you.
Right.
And then if they measure their blood pressure and everything is good, I can up titrate it via the video visit or the telehealth visit. And then they can come to the clinic at the time when we need to recheck their echocardiogram and see, if their heart function has improved.
Right. So I think that those social determinants of health are really important to look at from the context of our work. I know that I used to take a look at patients' neighborhoods and see what kind of food desert they were in.
Yes.
And when we kind of get a clue to that when we talk about dietary intake and what people are eating. And if you see that folks have a restricted economic status, looking at that diet and their ability to get out as far as activity is concerned are all related to social determinants of health in many ways, right? So I think looking at our work in the context of social determinants of health is really very important. Let alone the pathophysiologic variables that we see related to cancer and cardiovascular risk as far as inflammation is concerned, and what stress does for an inflammatory process. Again, social determinants of health, it falls under that entire same lens.
Right. And, one example I cannot, that can point out really, the social determinants of health, which includes the education, which includes, the environment of the patient. And you talk about food. I have a typical example in this that patients understand, because I was teaching the patient about, the heart failure diet, low sodium and all that. But anyway, the patient comes back to the clinic very frequently with heart failure exacerbation, swelling, and I cannot control I give them diuretics, but the swelling is still there, having shortness of breath, and is admitted to the hospital. So I sent a social worker to the patient's house to really look at what's happening in the house. Right. So when the social worker got in there, no, not the social worker, the home health nurse. The home health nurse got in there. The patient has a big bottle of pickles in his table. So the home health nurse said, "What are you doing with these pickles?" He said, "Well, I was told I need to eat vegetables. And pickle is the vegetable." And I told him, I said, "Didn't I tell you low salt?" He said, "No, I'm not eating salt." I said, "So what's the pickles about?" He said, "Well, you told me to eat vegetables." So that's what I'm saying, that, there is a disconnect in terms of education. And so when I tell them, low sodium, I just don't say low sodium. Canned meats, pickles, all those, because they cannot, some patients, it's straightforward, but that patient gave me a lesson on how to do patient teaching.
Well, get it. We go back and look at those two primary things that we were talking about conceptually. One was patient's perceptions.
Yes.
And patient education. So here's a guy who comes along who is eating cucumbers. That's what he sees. He sees this as a vegetable. He doesn't understand that putting it in vinegar and all the preparation that it takes to make a quote unquote pickle means that he's placing himself at risk. That's a great story.
Right. That's I'll never forget that one. That's why when I teach patients, like it brings me back to that. And I said, I just want to let you know, pickles is high in salt. So
Well, this is fantastic. Y'all, both of you exhibit such passion for this, as I said at the beginning, and we so appreciate your expertise, and we really appreciate you taking the time to kind of share with us, your strategies for assessing and then managing these patients. As always in these episodes, once we get into it, we realize it's super complex and there are so many issues to think about. But you all both have done such a great job in trying to summarize that for us. So, Jessica, thank you. Any closing thoughts?
I think the closing thought would be really related to those two concepts that we brought about. I mean, risk stratification is really important. Patients' perception of their risk is very important. And patient education is really vital in helping people cope and move forward into a pattern of wellness.
Perfect. Thank you so much. Anecita, thank you for taking the time as well. We always appreciate your insights.
thank you.
Thank you both. For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.